In this case, we have a patient with a mitral valve prolapse with an MR in late systole. There is a normal opening of the valve, there is clearly no SAM, but when you measure the continuous wave Doppler signal, you have here the aortic valve signal and here another very steep, very nicely to visualize signal. It's around 4 meters per second, 3.54 meters per second. But if you take a close look, this is due to the eccentric jet of mitral regurgitation. So what you're actually measuring is first the aortic valve signal and then a little bit of the MR. So this is an eccentric MR and this is a pitfall when you measure certain gradients. So what do we know so far? I want to emphasize again, E to A above 2 shows restriction. Be very careful with volume. The small E wave, the very large tall A wave shows you most likely there is more volume needed. Of course, the IVC, the lung ultrasound has to be concordant. The LVOT obstruction shows you that this patient will need more likely volume and you have to be really careful with catecholamines to not worsen the LVOT obstruction. And furthermore, you can check the left ventricle. The left ventricle, if it is small and hyperdynamic, this is the patient we have discussed before with the TAVR. If it is small and hyperdynamic, of course, in the clinical context again, with this kissing papillary muscles, so here the papillary muscles, the posterior medial, the anterolateral, and they are kissing each other, which means that there's hyperdynamic left ventricular function present, which again then could mean that there is volume needed. If the overall area is below 10 square centimeters, this patient most likely need volume. Of course, there are many pitfalls: left ventricular hypertrophy and hypertrophic cardiomyopathy, amyloid heart disease, also HFpEF heart failure with preserved ejection fraction by means of, for example, hypertensive heart disease. So we have to be very careful and see it in a clinical context. Furthermore, the pitfalls include, we said, amyloid heart disease, hypertension, but also if you use inotropic therapy, vasodilators, they can lead to hyperdynamic left ventricular function. The image quality is essentially, of course, all Doppler and B-mode measurements, but also the angle dependency needs to be addressed when you talk about Doppler measurements. In this case, here you see the first signal that was still in the aortic valve. Here you have the true LVOT signal, and here you have a different signal more towards inside the left ventricle. So also always question yourself, is the signal I'm measuring truly the signal I want to measure? What else do we have also in ventilated patients? Well, is the IVC when the patient has ventilatory support below 12 millimeters, it's with a very high likelihood that the right atrial pressures are below 10 millimeters of mercury. If the IVC with ventilation, so with respiratory support, has a relevant collapsibility there, you can calculate an index. If this index is above 18%, the fluid responsiveness is most likely. You can also simply check the IVC and see if it is approximately 20% collapsible in an intubated and ventilated patient. Of course, the PEEP shouldn't be too high, but if you see a certain degree of collapsibility, that would point towards a need for volume. A fun fact, the SVC, you can use the same formula, so the collapsibility index, you can scan it in TTE and TE with a cutoff of 36%, not 18%, so the SVC is normally more collapsible than even the IVC. If the IVC is huge and there is no collapsibility at all, I would be very restrictive with volume. Furthermore, you can use the pulsed wave Doppler signal. We have discussed it now several times. If there's a variation with the respiratory movement and the respiration of the patient, you see that and look at more signals over time. With also the respiration, you can even use a respiratory curve. And if you see a variation of above 15%, that most likely points towards fluid responsiveness. In a breathing cycle, if it is below 10%, there will most likely be no relevant fluid responsiveness. The stroke volume or VTI or even the maximal velocity, you can use a passive leg raising or a volume stress test. You can, for example, administer 250-500 milliliters of crystallite. This is a fluid challenge. And if the stroke volume or the VTI, you can also use simply a visual assessment like with the IVC and not per se calculate many indices. If you do that and you see with this passive leg raising or the volume administration that there is an increase of VTI or the stroke volume of more than 10 to 15%, there's also most likely that a fluid responsiveness is in this patient given. Of course, you have to have an optimal LVOT signal with pulse wave Doppler. You have to measure the signal before and immediately, and I would also recommend during a fluid challenge, during the passive leg raise test.